Whenever you do releasing incisions, you always want to close your wound first so that you can figure out where you need to make your releasing incisions and how tight it is. Feel that skin, that's way too tight, that's going to open up. Up here is obviously fine. This is my preferred method for removal in this area. I tend not to because most of the time when I'm doing a flap, it's for a tumor or a removal, it's for a tumor. I want to minimize the surgical field such that if we did need to do radiation in the future, it's a much smaller area. Anytime you do a rotational flap or anything like that, you're dirtying the field. I made an incision here. This didn't really open up, which makes sense because this is not next to my wound. So I know, okay, that's good. I don't need to keep going. And then we can do the same thing here.
I think I like that better than the flap.
And these holes heal in about the same time as the incision.
In terms of closing this one here, like 3-layer closure to me is always like muscle, subcute skin, but I don't have any muscle to close.
You can sometimes grab this fascia right here and bring it to this muscle edge or to this one here. And so you'll see even though I'm not closing anything totally, but when I grab the muscle and pull it up here, we're moving the skin as well. So every time you close, I always think about the closure of the deeper layers. The goal of that is to bring the upper layers a little bit closer together so that hopefully by the time you get to your skin, there's minimal tension there.
Once tumor is already involved with like a muscle, then how much muscle we can take out?
You can take all of it. I mean, if it's involved, there are not very many muscles that you can't take out with impunity. Especially if there's cancer involved, it's like it is what it is, and they're gonna have to figure it out. But I mean, I've taken almost all of this biceps. They do fine, you know.
So like no mobility issues.
No.